This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome back to the ICE Image of the Month. Today, our topic is intracardiac echo as applied to transeptal access, and specifically focusing on troubleshooting difficult transeptal accesses. And for that reason, I'm joined today by Dr. Eduardo Saad. He has two affiliations, one with Beth Israel Hospital in Boston, and then also Hospital Samaritano in Rio de Janeiro, Brazil. Welcome.
Thank you, Dan. Really a pleasure to join you today.
So, transeptal access, we do it all the time. When it goes great, great. But really, there are a number of difficult situations with transeptal puncture. So, we hope to have this episode be a resource, not only locally, but globally, for understanding ICE and really broadening its usage for difficult transeptal punctures. So for our plan today, overall, we'll start off with right atrial considerations and SVC considerations, imaging this area, and troubleshooting. I think there is a conception about CID wires and the difficulties with using ICE, so we'll show examples of how we can identify and manage around CID wires for transeptal puncture with ICE. And then we'll kind of go step by step through different challenging septums. Whether it's Amplatzer, laminated septums, aneurysmal septums, or small fossa, or big, thick lipomatous septums. So we'll really figure out ways to troubleshoot all these very difficult septa with ICE. And so, Eduardo, thank you so much for these wonderful images. I'll have you start off talking about SVC positioning. We've got the ICE catheter here in the right atrium with posterior flexion. We're visualizing the SVC, and I'll let you tell us about what we're looking at.
Perfect. Thank you so much. It's really a pleasure to join you today, Dan. Thanks for the invite. So this is the ICE catheter showing the SVC view with the wire inside the vein. And what we're doing after we cover the wire with the sheet, so we know that you are actually going up and you know what the level of the sheet is. You remove the wire and we inject in just saline, just proving that you can have a contrast, an echocardiographic contrast in the SVC, showing that it feels from the top to bottom, or from the head to the toe of the patient. So confirming the position of the tip of the sheet inside the SVC. So this is a very important maneuver for the initiation of the transseptal. From that point on, you're going to go down to the septum. So this is a very important confirmation, so we don't have any blind spots on our procedure.
No, yeah, I think this is a beautiful image. People often rely on fluoro to really get to the SVC and avoid critical structures. So I think your image here, where you really kind of bring out the SVC, but with your posterior flexion and demonstrating where the echo contrast comes from, is really helpful for people understanding and getting over that hurdle for using ICE for this important step of the transseptal. So your next image, I think, is a great one too. Avoiding the appendage, understanding how to visualize where your wire is going. I'll let you tell us a little bit more about it here.
Right. So this is critical, as you said. So it's very important for us to differentiate whether the wire is going truly in the SVC or in the right atrial appendage. As this image is showing, there is the SVC. If you give more posterior tilt, like you increase the amount of posterior tilt, you can bring up the right atrial appendage in view, and then you can differentiate both structures. So here we see the SVC with a decapolar catheter in it, and the wire is being moved on purpose from the SVC to the appendage and then back to the SVC, just to show that difference. So we see the J part of the wire. So at first it's going into the SVC, and then it's being pulled back and going into the right atrial appendage. So it's very important that we make sure that the wire is in the SVC to be able to advance it over the wire, because if indeed it's in the right atrial appendage and you start pushing the sheet in, you might come to the end of the wire, and the tip of the dilator, which is very pointy, very, very thick, in terms of pushability, can actually perforate the right atrial appendage. So this is a simple maneuver, but you have to make sure that you are in the SVC.
I completely agree. I think that from a safety perspective, understanding this close relationship and understanding how you can really, with really good definition, see both is important. I actually apply variations of this view also to leadless pacemaker implant with the Avere to visualize where you like to be at the base of the appendage. You like to be good tissue contact. So, I mean, this view has a ton of uses. And I think this is a great example of, again, improving safety with your eyes.
I will go beyond that. If you're into doing fluoroless pacemakers, that right atrial appendage view is awesome to put the atrial lead in with ICE guidance. But it's just a multitude of also of uses that you can have with this image.
No, I totally agree with you. And again, I think people have heard, they're probably sick of me saying this, but when you use fluoro to do these things, the heart is invisible, and we're imputing where this is. There's no guessing game. You see everything.
This is the important thing about fluoroless. I keep saying this all the time. It has to be. You can't have any blind part to it. You just have to be able to acquire the images, and it's possible to acquire the image to be able to be comfortable in seeing everything you're doing.
So I think also a common misconception is, the ability to perform transseptal or quite frankly, any procedure when with the presence of CID wires. And so you have a couple of very nice examples of how do you differentiate CID wires versus J wire, and how do you troubleshoot doing procedures with CID wires? And I'll let you narrate a bit of what we're seeing.
Okay, so on the image on the left side, we see as I said, the atrial lead inside the right atrial appendage, but it's also coming down the SVC. So it's very important that we are able to differentiate our J wire from the lead, because we're going to be covering the wire, but not covering the lead. So if we mistake one for the other, we might be pushing the sheet in, thinking that we're not yet there because we're not covering the lead, and that's not what your aim is. So it's very important to visualize the J part of the wire, as it's shown here, and the J part of the wire is going inside the SVC. So now that you're sure which one is which, it's easy to go up, railing the sheet over the wire and watching it being covered, but now you're sure that you know which one is which. In that fashion, I think it's very, very safe to go and to manipulate the sheet, even with 2, 3 leads. I mean, I've done cases with even 4 leads in, and as long as you are able to make sure you see the wire, it's very safe to do it. On the right side of the screen, we have an image just to show that once you use eyes routinely and you're watching the leads from a near field, it's very common to see lead thrombus. So this is a kind of, it's not unusual, and it's a warning for us. So sometimes you say, well, whether you think the patient has endocarditis or something, but otherwise it's very common to see thrombus. And sometimes, depending on the amount of thrombus that you see, this one on the right side of the screen is on the lead, but it's kind of in the middle of the chamber, middle of the right atrium, near the tricuspid valve. But sometimes they are clustered in the SVC. And as we're going to show later, maybe your transseptal technique might change a little bit if you see a high burden of thrombus in the SVC itself. But it's important that if you see a lot of thrombus, you try to minimize the amount of manipulation that you do. And you can only see that with ultrasound. So if you're using fluoro or anything else, you're not going to know it. You're going to be blind to that.
I completely agree. I think, for your first image, right, for advancing your sheet, this is very helpful. But also, again, also for the drop, right? As you come down, making sure you're not putting any stress on the leads. And if you do see that you are, you can very quickly kind of rotate your sheet to release the leads and continue your drop. So I think important imaging there. And I completely agree with you with regards to fibrinous stranding or thrombus on the leads. Really, as you're manipulating anything within the chamber, especially if you're going to push it left-sided, you need to understand where these thrombi are and how you can avoid them. So perfect examples of CID troubleshooting with ice, especially in the context of the transseptal puncture. So I think foundationally, right, we're going to start off with the standard transseptal and then get to the more advanced or difficult septa. So I'll have you narrate your transseptal here.
Okay, so this is a standard transeptal access, no special issues about it. But what the image shows us is that we see the drop from the SVC to the septum, and then we see the septal tenting. We go across the septum, and I like to do, so going back, this is the drop and the tenting of the sheet. This is the needle going inside the left atrial chamber. Now I remove the needle and put a J wire inside the left pulmonary vein that's on the bottom of the screen. So in that way, we are not only we have a lot of precision in terms of choosing where in the septum we're going to cross, but once you have a wire in the vein, you can advance the sheet and the dilator over the wire, making it very safe. So I think this is the point of this standard approach, is that it's possible to see every step of the way, from the drop to the fossa, to the tenting, to the advancement to the left atrium.
Yeah, I think this is the transseptal we all love to have and we love to do, right? You're able to rail everything over the wire into one of the pulmonary veins. It's a slightly posterior facing puncture opposite the veins, which works very well, I think, for RF ablation.
Yes, this puncture it was done exactly for an RF case. So you like to do it at the level of the left pulmonary veins and mid to low in the septum. Well, I mean, maybe in the next example, you're going to show that if you're using the transseptal, this is it, for VT ablation, or even nowadays for PFA ablation, you want to free yourself from more space. And we like to go across more anteriorly on the septum and maybe more inferiorly as well. And so in this view, we see that we have the dilator already across to the left atrium. And we are also seeing on the same clip the mitral annulus at 6 o'clock and the left atrial appendage at like the 5 o'clock position exactly. So this, so the ultrasound beam is pointing more anterior, so showing that your transseptal was actually inferior and more anterior. So this will be a bad spot for a PVI using RF, but I think it's the sweet spot for VT, for LV manipulation, for left atrial appendage closure, and for PFA ablation as well.
Yeah, I think this is valuable, right? And you're right, the critical structures in view, the mitral annulus and the appendage. I think, when you're low and anterior, you have an easier access with your deflectable sheet to get into the left ventricle. You can do that all with ICE guidance without the need for fluoro. And in the case of larger bore PFA technology, when you go low and anterior, that gives you purchase to be able to rotate the larger system around to reach the right-sided pulmonary veins, which understanding the degree of offset of those veins from the septum is also helpful to do with ICE guidance, probably out of the purview of this particular segment, but really that whole offset will help you understand how you need to manipulate your catheters. And then the more you can kind of create distance with your transseptal puncture, specifically like in this example, will allow for that manipulation.
Oh, just, if you spend time doing it, it will be, you mean saving time later on when you have to access, especially that septal and inferior border or the right inferior pulmonary vein, exactly as you said, because, it will be much easier to rotate and actually engage that space.
Exactly. So I love this technique. It's like it's the poor man's RF wire. I use it all the time. A beautiful example. I'll let you talk through this technique and when you choose to use it.
Yes, so I like it too. It's very cheap. There's no extra cost involved. So this involves a transseptal puncture without a needle. So as you see on the picture, it's just the sheet and the wire. There's a standard guide wire, J wire that comes in the sheet. So once you have a good tenting, you just press the wire out and bovie the tip of the wire. You usually use around 20 watts on the cut mode. So once you do that and you have a great contact with the tissue, the wire will just slide to the left side. And then once you have a wire on the left side, you go to the left pulmonary veins and just advance the whole assembly to the left atrium. I like using this, and you can use it for every case, but I like to use this technique, especially when you see a high load of thrombus on the leads, for instance, in the SVC, as I mentioned before, because then I don't have to go all the way up with the sheet and dilator to the SVC. So you can actually go to the mid chamber with the lead, with the wire and then advance the sheet. As you pull down the wire, you're going to engage the fossa. And once you engage the fossa, you just go across. So it prevents you from having to go on the SVC when you have a lot of thrombus in there. So that's one of the good uses of it. But I think I guess you can use that any time. There's no drawback in using this, and you avoid having to use the transseptal needle. Just a word of caution here: it's easier to have a great amount of tenting necessary to have the wire going across if you use a deflectable sheet, because then you can actually use a deflection to make sure you have really good engagement on the fossa. But it's possible to do it also with a standard sheet as well.
I love this technique for, septa that have already been previously accessed. Maybe you need a little bit more to cross, even if it looks thin, it's a little scarred. And also, the examples you discussed. So nice example and beautiful images.
Yeah, just calling attention then to that last part. So once you have the wire inside the left veins, it's important to advance, especially when the sheet goes across the septum, because there's a jump between the dilator and the sheet. So it's very important that we are actually seeing that you have extra wire inside the vein in order to push the sheet across the septum. So this is the important thing. So you make sure you see at the 5 o'clock position that you still have the brightness of the wire available for extra room for the sheet to advance.
Yeah, the jump with the step up, really, if you don't have something railed into something safe, that's when you can have a perforation issue, and perforation in the left atrium, as you know, it can be a very, very difficult situation. So.
Absolutely.
So, Amplatzer devices, I think that, ICE makes these procedures easier because you can understand, where is their thin septum that we can go around the Amplatzer device. And I think this is a source of anxiety for a lot of operators getting around these. And I think you illustrate a perfect example of how we often get around these. And this is not visible with fluoro guidance. This is really, the best way to use ICE to get this done. So I'll let you narrate this video.
Yeah, so this is a patient of a heart failure and a big left atrium, and it's usually when they have this Amplatzer and the septum, you have like a posterior rim of tissue, low and posterior, that allows you room to go in. So this is what we're doing here. We are actually found that spot, so we have the sheet in there. So once you go across, you don't see it perfectly well in that view because you have some shadowing from the device, from the metal of the device, but it's possible to see that we were tenting there once we advance, even if I was not perfectly seeing the tip of my dilator in the left atrium. Just by injecting saline, you see that bubble puff in the left atrium right there. Now see the bubble puff? So we know that we're in the left atrial cavity, then you just use the wire. If you advance the wire in the left pulmonary veins, it's game over. Then you safely inside the left atrial cavity. So this is an important point. So we see the needle going down all the way along the device until we reach that specifically narrow rim of tissue, and that's where you have to go across. So, but it's very precise, and ICE is the technique that allows for that amount of precision.
No, I agree. I think that inferior posterior rim is often your best ticket, if possible, with these devices. And you're not going to see that without ice. And then additionally, yes, you do have some artifact related to sound reverberation off of the Amplatzer device. But I see you've got some posterior until you come off of that Amplatzer a bit. I think you can still see the tenting, regardless, from a safety perspective, right? Injecting saline to know you've accessed the right chamber, as well as advancing your wire so you know where your apparatus is going to go, all critical for safety. And really, you can make something that can be anxiety provoking quite technically challenging yet interesting with this approach.
Absolutely.
So the laminar septum, go ahead and give us your narration, your approach.
Yes, so this image shows two examples of a laminated septum. So you see that you have almost like a space in between the two layers of the septum. And it's important when you see that to realize that you have to go across twice. Let's say you're going to have to go across, and you have to choose where's the narrowest space between the two layers. In this case, was very low in the septum. And you see that it's almost like the septum continues as an extra membrane covering the left side of the septum. And in this case, it's easier to go and avoid that area. And so it's another reason to go low on the septum, where it's usually those two layers come together. As in this example, it's easier to go the lowest you can, but you have to realize that you're going to have to go across twice. But otherwise, it's about the same. It's a different appearance. And maybe when you look at first, say, oh, it's going to be a very hard day in the lab to go across. But it's usually not. Those layers, at least in my experience, most of the time, they are not thicker or not even harder to go across. You just have to realize that you're going to have to go across twice.
Yeah, I think there's a fair number of people that use the tactile feedback, right, for the transseptal puncture, and maybe they're not using ice as much. And so really understanding that the tactile sense is going to feel like two punctures, and really visualizing the apparatus getting through both before you inject your saline and advance your wire. So I think this is the aneurysmal septum is an underappreciated, difficult, and potentially dangerous situation. And I think, understanding if it's your initial image, hey, I have an incredibly aneurysmal septum, what's going to be my approach, will help you kind of get through this situation safely. And I'll let you talk a little bit through these images as well as your approach.
Okay, so this is a tricky one. So as you see, the aneurysmal septum is usually very floppy and very hard to puncture. So what you see on the second image is that it doesn't matter how much pressure we put on the septum, it tends to go all the way to the posterior wall. So the danger in that situation is that if you use just a standard transseptal approach with a needle, is that once you are actually able to advance the needle inside the left atrium, the pushability that you're doing, it's going to take all the assembly to the posterior wall, and maybe you have a perforation because you don't control how much forward pressure you put in. So this is what you have to be careful with. And my approach to those septums is that I do prefer to use some sort of power needle. It could be just a wire with the bovie, as I said before, but any type of power. It could be a powered needle, could be a powered wire, or just bovie on a standard wire, because with that way, you avoid having to push too much. You just have to have a good tenting, and then you use the energy to go across, and you don't have a pointy structure going across. You just have a J wire right away. So this is the septum where I would prefer to use a non-traditional approach or a needle, avoid a needle unless if it's a blunt needle with a power on it. But the main message here is that an aneurysmal septum, be careful how much pressure you're going to push forward.
Yeah, I always say with EP, right? The solution is rarely pushing harder.
Yes.
And in this situation, right, the more force you're applying, right, eventually you're going to push towards the posterior wall. Say you actually get that jump, you can get yourself into a lot of trouble. I agree that some sort of powered needle or assembly is helpful. The other point I'll make is the safe step wire. You know, what I often use in this situation is you tent to a degree, then you put your safe step wire through. It immediately it punctures because it punctures, and then it immediately jays as well. You can put it into one of the veins and rail over it as well. But you need to have a strategy, right? Because just using the needle is actually, I think, where you can get into trouble.
Absolutely agree. The traditional approach here is somewhat dangerous because you don't have that much control of how much pressure you need to go across. It's about the same amount of pressure that you need to go, that you need to actually provoke a perforation in the posterior wall.
So small fossa, you know, really a small window. And one of the things we don't love to see. Talk us through identifying it and managing it.
Yes, so those are really the hard ones. So thick septums, thick limbuses with the small fossas are not as uncommon, but those are the hardest ones because, and these clips show exactly what we don't have to do, because you see that you have a very small fossa that we missed. So while engaging that fossa and advancing the system, everything's lighted up towards the thick limbus, and actually we pushed in enough to go across that thick part of the septum. Yeah, I mean, that's not a huge problem because nothing happened, and then you can manipulate the sheet through that. But that's not the appropriate technique. I mean, the best place to go across is that small little fossa that you see there. So this example shows us that if the most that you have to troubleshoot in that situation is that you will need to not only engage that small fossa, but trying to work your way without pushing too much so the system doesn't slide up to the thick portion.
Mm-hmm. And I think that, you know, when you have thicker septum and your ultrasound beam has to image through it, you know, it can reduce your image quality to a degree, but in your example here, it still is quite good. I think for those who want to troubleshoot this, sometimes you can pull down the ice catheter too and try to get, you know, as little tissue as possible between you and the structure you're trying to imaging. That being said, if you go too low, it can be hard to see more distal into the left side vein. So I think you did a very nice job here. And then I think we'll progress on to, this is an incredible image, septal hypertrophy, your lipomatous septum. This is one of our greatest enemies. And I think we'll spend a little time here talking about imaging this and your approach to really getting across, which can be really challenging, even after you've punctured.
Yes, and I'm gonna, for full transparency, I'm gonna have to say that this case was probably the hardest transeptal I've ever done in my life. So this is the amount of hypertrophy that the septum has. And so I think it's thicker than the LV wall, and you see that the fossa is so small, and this is like the dilator right at the fossa, but it actually it creates a shadow on the left side. So when you went across, you cannot clearly see. Not even the wire. I was able to make sure I advanced to the left side. I advanced the wire, but I couldn't see the wire in the left side because that huge septum really creates a shadowing that you cannot see what's, you know, I couldn't be sure whether the wire was in the left veins or in the appendage or elsewhere. So after I was able to engage that fossa, which took a long while, and after I engage the left atrium with the wire, I actually fluoroed to make sure that I could see the wire, and then I went across. And after I went across, I actually pulled back the sheet and I went across with the ice catheter. Then then night becomes day. After you go with the ice on the left side in a septum like this, you leave everything behind, and then you start seeing everything. But those type of septums are rare, fortunately. But you know you're going to have a tough time going across.
And I would say, right, there's no shame in if you want to verify where your wire is using fluoro, especially when the image can be this distorted. I mean, I think you have to use all the tools at your disposal. You know, with septa like this, what I find is you can get through, right? And you can even get your wire, but getting your system across, the rest, getting the step of everything can be very difficult. And I'll just kind of share, I wish I'd included my own image here, but what I find is, so I use, for RF, I use a single puncture and 2 sheaths. And so I will advance the wire out the left-sided pulmonary veins. And if I'm unable to eventually advance through the step up, I'll dilate to the best of my ability, pull back, keep the wire, advance my ablator through that septum, and then actually move it to each pulmonary vein, and then clock it into the right inferior pulmonary vein. And and then park it there. And I find that actually kind of draws the septostomy open a little bit, and then I'm able to get everything in. Just a technique for these difficult septa, which if you don't have a strategy, can be difficult to complete your procedure and to complete it safely.
Couldn't agree more, but I think that the main message of this type of image is that fake limbuses are an enemy for ICE imaging from the right side. You're going to have to make your best to try to see the fossa, and maybe to try to visualize the left atrium from that fossa and not through the thick septum. You're going to have a shadow, but it's possible, even in those extreme scenarios, to go across safely and do whatever you have to do in the left atrium.
No, I agree. And I think your point about left-sided ICE, advancing your ICE catheter over the wire, butting it by the wire to get into left atrium, night becomes day, right? As you said. And left-sided ICE, I think, growing in popularity in the era of PFA. More to come on that. I know that you're a big proponent, as am I.
Absolutely. I think it's especially, as I said, with PFA, it became more and more important, especially for floorless PFA. I think that's key to having great visualization of the contact of the catheter and the position of the wire. So that's no question that left sided ICE, it's a game changer.
And Eduardo, I think that you have a very unique perspective, right? As someone that practices in 2 different environments, a floorless, high, ICE heavy operator. I guess my final question for you is, as someone who has practiced in both environments, given the kind of the omnipresence of ICE in the U.S., and even here we're trying to push operators to do it in a more advanced way. Then thinking of those barriers globally, the global adoption of ICE. Can you comment on your journey to using more ICE, and then maybe talk to our global audience and tell them, the value of ICE and how can we more globally use it?
Yeah, thank you for that question. Then I since the early, I think it was about 2003 when I finished my fellowship in the US and came to practice in Brazil. I was truly engaged in having ICE available for me there. So it was a lot of barriers because of cost issues and trouble with sterilization and re-sterilization of catheters. So I have made a decision that I would not just allow that to prevent me from using it. So I did everything I could in terms of actually showing not only insurance payers, but also hospitals and even patients the importance of doing whatever we need to do to have it available. I truly believe that with ICE, I think we have less complications and more precision. So especially in the the Latin American environment, but cost containment is really a very important part of our job. I think that having it available at the lowest possible cost, having it, if it's safely being re-sterilized and with protocols and that you can keep track of, can actually make it available more widespread than we thought before. And the second task was, after that, was actually educating other people in using it. Because once you show those images and say, well, most people say, oh, I love it, I want to do it, but I can't get those images myself. So actually engaging in educational programs to allow other people to, have their learning curve and use it at, that amount of advanced imaging, it's very important, because then now you're not the only man trying to sell that technique, but everybody's pushing to it. So, together we have more power. So I think that's what happened in Brazil and maybe now in Latin America as well, that we started off trying to explain and to create the environment to have it available, and then increasing the mass of people that are actually using it.
I completely agree. A couple comments on what you just said, which was just beautifully said. Number one, cost containment and consciousness it is also a concern here in the United States, and something that we need to think about, especially in the era of PFA. And number two, just based upon your own story, right? Seeing the value of ICE, this segment is an example, right? Seeing the value from a safety and efficacy perspective. And I would like to challenge, our professional society as well as industry. We want to, to partner to make ICE's global use more prevalent, because I think these barriers are not insurmountable, right? They're educational and they're cost driven. And, I think if we more globally adopt ICE, all of EP wins, and especially the patients. So, I'd like to challenge, our partners to really take this to the next level.
Couldn't agree more. And I think that's exactly the point.
Well, Eduardo, thank you so much for a great segment. Thank you for joining me.
Oh, thank you. It was really a pleasure and an honor to be part of it. And I hope, we had a useful and practical discussion on a very important subject.
And thank you all for tuning in to Heart Rhythm TV.